The first thing we're going to do is just go down here, go to cadavers, scroll down. You're going to see high resolution ear right here, and it's going to show you a picture of just the eustachian tube. And when we load it, that's kind of what it looks like, but we don't care. We're going to go ahead and just add everything that we wanted to see on there. No big deal. So we're going to start off by looking at the superficial structures of the ear. Okay. The first thing we're going to see right through here is the auricle, and I won't ask you auricle on your test. I'll ask you one of the landmarks on the auricle. So this part right through here, this is the helix. And then as we get down to the inferior portion right through there, we're going to see the lobule, or the earlobe, the part that people frequently get pierced. There's another little lump right through here. It's not significant on this cadaver, but this piece right through there, and that's known as the tragus. Okay, so the tragus is this little lump on the inside portion, and the antitragus is this part right here, just opposite of it. All right, we'll do it maybe just in a different color so we can see that. So if we were to put maybe a pin like right here, we're going to call that the helix. Pin right through here, that's our ear lobule. Pin right through here, that'll be the tragus. Pin right through here, that's our antitragus. We okay with that? Okay, let's get rid of our initial drawings, and then let's draw a couple more. On the inner portion of the ear, there's this depression, and it's taking essentially all the sound waves, and it's trying to direct them this way. Okay, that portion right through there is our concha. So the concha of the ear is responsible for trying to collect sound waves and then pass it into the opening for the auditory meatus. So again, if we had maybe a pin right here, we would say that that's the concha. If we were to instead have a pin like right here, this would be the opening for the external auditory meatus. Now, the opening itself is the soft tissue that you find inside of the tissue, the skin. And then when we remove that, we see the opening for the eustachian tube or the external auditory meatus. Are we okay with these pins right through here and what they're called? 1 is the helix, 2 is the lobule, 4 is the antitragus, 3 is the tragus, 6 is the opening for the external acoustic meatus, and then number 5 is representing the concha. Now let's remove the skin. Let's go ahead and remove the pins, and then we'll remove the skin. Okay, when we do that, we can now see the cartilage of the ear. We don't really care, it's not on our list, so we're just going to remove that as well. All right. And one thing we're not really seeing at this point, so I'm just going to add it on here, is the auriculotemporal nerve. The auriculotemporal nerve is going to be the nerve just anterior to our external acoustic meatus. So essentially supplying the anterior part of your ear where the tragus was, and then part of the canal itself. So that nerve comes from the trigeminal nerve, and again, not surprisingly, trigeminal is sensory to most of our face and even the cavities of our head. Now, I'm going to remove the arteries because we don't need those right now. And as we look inside the eustachian tube, you probably can notice that there's something in there. Okay, this thing right through there is our tympanic membrane. I'm just going to give it a little bit of color. And remember, the tympanic membrane, if we were to look at it this way, this is superior because this is the top of the head. This is inferior. If we look at the superior part of the tympanic membrane, we can sort of draw the letter V here. And that area represents what we call the pars flaccida. Now, when you look at this, you're not really going to see anything, so you just got to kind of know that the superior portion of the tympanic membrane is the pars flaccida. The inferior portion, everything below there, about 2/3 of that, is going to be the pars tensa. Okay, so again, pars tensa is the inferior portion. Okay, so number 1 would be pars flaccida, number 2 would be the pars tensa. Now, what's putting tension on the tympanic membrane? If we pull it out and just kind of draw a little circle, when we look in each other's ears, we're going to look through the eustachian, or rather, we're going to look through an otoscope inside the ear, and we'll see the tympanic membrane. You can actually see through that. It's semi-transparent. It can be a little cloudy at times, but you should be able to see it. When you look inside, you're going to see this little thing hanging down just like this. That little thing right there is the tip of the malleus. So you can actually see the first inner ear ossicle through the tympanic membrane inside of your patients. So if you're looking with the otoscope, you can see that. That puts pressure on the tympanic membrane. It actually pushes on it, and that's what causes the pars tensa to have the tension applied to it. Does that make sense? The superior portion, like this part up here, if we said this was the pars flaccida, is loose, meaning that if there's an increase in inter or middle ear pressure, it can swell a little bit and it can stretch without popping immediately. All right. So again, the umbo is going to be seen through the tympanic membrane, which is the way it's written on our list. But when we look here, we can't see anything, right? Or at least I don't see anything there. So again, I'll show you that as part of the inner ear ossicles, but you won't see it from the tympanic membrane. Okay, we're going to take our blue cutting tool again. We're going to then cut into the head, and then we're going to essentially look for a couple of markers. Okay, the markers that we're looking for are going to be just past the tympanic membrane, right about there. We could do it that way, but that's a little bit too much. So we're going to back off just a little bit, and then I'm just going to remove the tympanic membrane. Get rid of that, get rid of our pins. Okay. So what are we seeing? What we're seeing right through here are two essentially openings. Let's kind of draw our outline around it. You see this right through here? The inferior portion right here is our tympanic cavity proper. The superior portion that we see up here is the epitympanic recess. So the space that's above the inner ear ossicles is the epitympanic recess. The space inferior to the inner ear ossicles is the middle cavity proper, or the middle ear. Let me say that again. Tympanic cavity proper, or the middle ear. You can say it either way. Are we okay with the difference between the two? Because that looks a little weird, right? How would you know what's what? What's your landmark to let you know when you look at that on test day so you don't miss the easy question? These ossicles. See those ear bones in there? Those ear bones are going to be our landmark to let us know what's superior and what's inferior. We okay with that? Now there's a piece of bone just above the epitympanic recess known as the tegmen tympani. Okay, you see this little space of bone right through there, and you see how thin that is? See, it's only about that thick, whereas these other areas are like this thick. It's really thick. That area of the tegmen tympani, or that bone, is special because if there's too much pressure build up inside the middle ear and the tympanic membrane doesn't pop, letting the fluid disperse, if there's fluid buildup, it can actually crack that at the tegmen tympani, spreading an infection inside the cranial fossa. You don't want that, right? So instead, what typically happens is that the tympanic membrane itself actually pops and gets a hole in it, and then the fluid actually passes out of your eardrum. If the tympanic cavity, or excuse me, the tympanic membrane pops, will you be able to hear out of that ear? No, you can't really hear very well out of that ear. Typically 4 to 6 weeks, it'll recover, and then you should be able to regain the hearing, unless it happens too often. If it happens too often, scar tissue will build up in the tympanic membrane, and then you can actually end up with deafness as a result. Are we okay with those spaces? Tympanic cavity proper, epitympanic recess, tegmen tympani. Let's look for our mastoid process. Let's zoom out just a little bit. See, as we zoom out, here you see that lump right through there? Okay, that's the mastoid process. Now, inside the mastoid process are lots of little air cells known as the parotid sinus, or just the mastoidal air cells. It also continues to go all the way up here to where you see this canal. So that portion right through there is actually known as the mastoidal antrum, and it makes up essentially the posterior wall of the tympanic cavity proper. How are you going to know that's what's tagged? You'd be able to see these mastoidal air cells. I'll make sure you can see this lump for the mastoid. We okay with that? May not like it, but at least we have a landmark there so we can see it. Now let's remove all of those. Remove the nerves, remove our pins. Let's go here to the skeletal system, and then let's put our middle ear, which is going to give us just these bones right through here. Now the bones themselves are pretty easy. Let's put them in anatomical position through here. They're really easy. One of those bones is going to be the malleus, and that's going to be our first inner ear ossicle. So there's our malleus. And your malleus has got a few different parts to it. Okay, let's turn it down. The first thing we're going to see right through here is the head of the malleus. Just below that, you're going to see the neck of the malleus where it gets nice and kind of thin. And then we're going to see this thing that looks like a long candle. Doesn't that look like you could maybe grab it and then hit somebody with it? Probably wouldn't hurt very hard or much because it's so tiny. But that's known as the handle of the malleus. Now, if you remember earlier, I said through the tympanic membrane, you can see the umbo of the malleus. The umbo is the very tip. If I tag this on test day, I literally just tag it right there at the very tip of the malleus. Okay, so the very tip of the malleus right through there is known as the umbo, and it's at the end of the handle of the malleus. Let's remove the malleus so that we can see the incus just a little bit better. The incus itself has got a few different parts to it. And this is a really ugly incus. There we go. Maybe that looks a little better. We're going to see that we have the body. We have this part here known as the short limb. It's just this little part that sticks out. We have this part here known as the long limb. And then if you look at it, you're going to see that there's this part that kind of curves right through here. It almost looks like somebody's knee. That part right through there is the landmark to know where we see the lenticular process. The lenticular process of the incus is the part that actually articulates with the stapes. When we look at the stapes, the only thing we really need to know is that this is the stapes, and then this is the base of the stapes. The main reason we would need to know that the base of the stapes is the base of the stapes is because that's what attaches to the vestibulocochlear apparatus at something known as the oval window. Are we okay with the inner ear ossicles? Let's take a look at the inner ear. When we look at the inner ear, I want to put it back in anatomical position for us and then zoom in. So the first thing we're going to see are the semicircular canals. Okay, see these semicircular canals? One of these guys is pointing directly to the side, towards where the ear would be. That's the lateral semicircular canal. Let's put a pin in it. It's our lateral semicircular canal. If I turn this down a little bit, I'm looking at the back. So that tells me that this is the posterior semicircular canal. And then by default, there's only one left, right? So that one that's left has got to be the anterior semicircular canal. Now, inside the semicircular canal are ducts filled with fluid. I can't show you that, so I can't test you on that. Do you notice how you have a nice slender tube that then suddenly kind of gets big and fat as it meets this part right through here known as the vestibule? Let me show you what I'm talking about. See how it's nice and it's thin, it's the same size, and then suddenly it kind of swells. Kind of swells where it hits there. That's known as the ampulla. Where each semicircular canal connects to the vestibule is going to be the ampulla. So there's more than just one of those. It's essentially the base of where these connect into the vestibule. Now, inside the vestibule itself is going to be two structures that I can't test you on because I can't show it to you, known as the utricle and the saccule. But I can test you on this little depression you see right through here. You see this guy right through here? And we're going to pretend that it looks a little bit like an Easter egg. That's the oval window. The oval window is located on the vestibule. If you look down here on the cochlea, there's a big circle. That's known as the round window. So the round window is on the cochlea. The oval window is going to be found on the vestibule. Now, inside your cochlea is the part that allows you to be able to hear. You're going to see something called the cochlear duct, and there's going to be a network of nerves and all that stuff inside there, but I can't show you any of that on the anatomage table. So I can't show you scala vestibuli. I can't show you scala tympani. I can't show you the vestibular membrane. I can't show you the organ of Corti. I can't show you any of those internal structures for the cochlea or the membranous labyrinth. So none of those will show up on your anatomage test. On the back of the ear, we are going to see that there's some nerves. See the back of the ear back here? And we're going to highlight it. And when we highlight it, the entire thing is going to highlight as the vestibulocochlear nerve. And it is the vestibulocochlear nerve. But what we need to know is that where it branches or where it splits, one goes to the vestibule. So this is the vestibular branch of the vestibulocochlear nerve. The one that goes to your cochlea is the cochlear branch of the vestibulocochlear nerve. We okay with that? Let's see. I think the last thing I need to show you is going to be the facial nerve and the greater petrosal nerve and the geniculate ganglion. I can't show you that on this cadaver, so I'm just going to minimize it down. And then hopefully I can show it to you on Victor. Let's see, maybe he's in the middle. Yeah, okay. All right, give me a second to get to it. We don't need any of the muscles. We don't need any of the muscles. What nerves do we need? Let's see if this works. Let's get rid of all of this except for these guys. Maybe that'll work. On some of the cadavers, it's actually really tough to get what I want to show you. All right, let's put all the bones back in place. Okay, let's get rid of all the arteries. We don't need those. Muscles, don't need those. Don't need that. Okay. What I'm going to do is I'm going to go inside the skull. And what I'm looking for is the temporal bone. Okay, so I'm going to get rid of the frontal bone. I got rid of the parietal bone. And now what I can see right through here is going to be the petrous pyramid of the temporal bone. Now, if you remember, inside the petrous pyramid of the temporal bone is where we're going to see our vestibulocochlear nerve and our facial nerve travel inside to get to the ear. So those are both traveling together. Now, what we're going to do is we're going to take the temporal bone and then we're going to use this feature right here to ghost it out so that we can see through it. So now we can see through the temporal bone. Now, when you look at that, don't get overwhelmed. Instead, look for what you know. So let's blow this up a little bit and look for something we can see. If we look right here, I can see this guy, and I know that that's got to be my semicircular canals, right? So that means that the nerve that's going to the back of that has got to be my what? It's got to be my vestibulocochlear nerves, right? Now, the facial nerve, it actually travels with the vestibulocochlear nerve, but if you look at it, it completely bypasses the vestibulocochlear apparatus. Instead, what it does is it goes to this little area and it bends, goes here, and then it goes back this way. Okay? Where is it passing through? It's passing through this ball of tissue known as the geniculate ganglion. Now, the part that's going towards the semicircular canals is going posterior, and that's the continuation of the facial nerve. The other part that's going anterior away from the semicircular canals here is the greater petrosal nerve. So the greater petrosal nerve will be found anterior to the geniculate ganglion. The facial nerve, though, itself will continue past the ganglion and continue passing through the middle ear. Now, there is one last thing that I didn't show you on the other cadaver. Here. And that's this connecting tube right through there. This is the eustachian tube or the pharyngeotympanic tube. The pharyngeotympanic tube is what's going to connect our middle ear into the nasopharynx. Okay. So again, the eustachian tube is going to be surrounded by this cartilage, which is partly what allows it to open up and equalize air pressure. Is there anything on your list for the ear that I didn't show you or didn't mention that you won't be tested on? Sure? Yeah?
Did you do the tensor tympani?
We didn't do those muscles. There you go. Thank you. Let's get rid of the skeletal system and let's add in the muscles. Let's add in the muscles for the ear Let's add in the bones because it won't make sense if we don't see it with the bones. Middle ear, let's get rid of the nerves. Let's get rid of the pins. Tensor tympani. So what bone did we say contacts your tympanic membrane? Remember the bone we said we would see it through the tympanic membrane? And if you're getting tired, I appreciate that. I am too. The malleus. So a muscle that's going to cause tension on the tympanic membrane likely is going to be connected to the malleus. Does that make sense? So this muscle you see connected here is the tensor tympani muscle. Now, not surprisingly, there's another muscle connected to your stapes. And it's named the stapedius, and that's the part that's not surprising, the stapedius. Stapes is the smallest bone in our body. The stapedius is the smallest muscle in our body. Okay. Anything else on your list?